Today, let's talk infectious disease and some common infections that we will come across. First, let's make a distinction between contagious conditions and non-contagious conditions. So, whether or not that disease can spread from person to person via direct contact, or whether it doesn't. So, on the non-contagious side, things like Lyme disease, tetanus, we can't pass that from person to person. If I'm infected, I will not make you infected. On the other side, the contagious side, yes, things like the flu, lots of viruses, RSV, COVID. If I have it, I can pass it on to another. And if that disease is contagious, we see this chain of infection in which we've got this infectious agent. Let's say it's a virus. It's going to need some sort of reservoir in which to grow, in which to flourish, some portal of exit, maybe a cough, maybe body fluids, things like that. And that mode of transmission, wherein the other person, say it's a droplet, it's a cough. Well, that other person inhales those droplets with the virus in it. There's a portal of entry, might be through the respiratory tract here in this case, and then a susceptible host. So the person taking in those viral droplets, are they susceptible to infection? Maybe they have a compromised immune system, or they don't have any immunity to that virus, to that bacteria, to whatever it is. There are stages of our infectious diseases, starting with the latent period, and here's latent period right down here. So these periods do overlap. We'll talk about each one on its own. The latent period, so the pathogen has invaded the body. The infection is there, but that infectious agent, whether it's a bacterium, whether it's a virus, whatever it is, cannot be passed, it's called shedding, cannot be passed to someone else, and it does not cause any noticeable symptoms. So we've got this short latent period. Overlapping that is the incubation period. Incubation period typically lasts a little bit longer than the latent period. But that incubation period is that period between exposure and the first onset of symptoms for the patient. So this varies in length depending on the pathogen itself. Can be as short as a few hours, or can go years at a time. Then we have the communicability period, which follows the latent period. Again, we're down here. And this period just lasts as long as that pathogen is present and can spread to other people. The disease period, right up here in red, follows the incubation period. And during this disease period, you might be clear of symptoms, free of symptoms, or there may be overt symptoms. So this disease period, which the disease is active, and depending on the pathogen itself, depends on whether or not you are experiencing symptoms. Luckily, we have a whole library of vaccinations available to us. The big ones that are recommended for EMS personnel, for paramedics, COVID-19 and flu every single year. Hepatitis B viruses, Tdaps, MMRs, and varicella, which you usually get as a child. Keeping active or up to date with meningococcal vaccines, and Tdap every 10 years. Now let's start with some specific infectious diseases, beginning with HIV, human immunodeficiency virus. This results from one of two retroviruses, either HIV-1 or HIV-2, and generally what they do, or broadly what they do, is they're converting RNA to DNA after entering their host cell and creating mutations therein. HIV infections come in three stages, progress through three stages. Stage 1 is acute HIV infection. Just a few weeks after exposure, you start to experience flu-like symptoms, fever, sore throat, things like that. Stage 2 goes into clinical latency. You have no symptoms, and the virus is still reproducing, but it's reproducing slowly. And if we've caught it, taking antiretroviral therapies can have significant effects on the viral load and your likeliness to transmit it to someone else. So using that antiretroviral therapy early on and properly goes a long way in preventing transmission. And then stage 3 is when HIV progresses to AIDS, acquired immunodeficiency syndrome. And in here, this immunodeficiency syndrome, you are prone to any infection. Think pneumonias and just the flu can really have a huge effect. So look for chills and fevers, swollen lymph nodes, lots of weight loss and weakness, and your body's immune system is just becoming more and more useless in this stage. So as a virus progresses from HIV to AIDS, they are two different things. With HIV, you can take antiretroviral therapy, ART, and control the HIV and control the spread of HIV, even becoming undetectable via our common lab tests. If it does progress to AIDS as the most severe stage of the infection, at that point, ART, the antiretroviral therapy, is not going to do much for you. And therapy is going to be more geared towards symptom management, quality of life at that stage. Next up is hepatitis. And hepatitis, inflammation, disease of the liver, first may not produce any symptoms, but typically you've got this abrupt onset of flu-like symptoms, fever, fatigue, nausea, vomiting, and then looking for abdominal pain, and then jaundice and dark urine are telltale signs of hepatitis or issues with the liver. The hepatitis viruses come in different types. First is hepatitis A. Good news here. There's a vaccine for it, and it is vaccine preventable. Hepatitis A is mainly spread and acquired by taking in contaminated foods and drinks. So, contaminated water, fecal oral route. So contamination carries hepatitis A with it, but again, good news, there's a vaccine for it. Then hepatitis B, found in blood and body secretions, usually transmitted through needle sticks, blood transfusions, infected blood products, through skin cuts, abrasions, and absorption through just your mucosal surfaces. Again, good news, there is a vaccine for hepatitis B. Most, if not all, of us have had a hepatitis B vaccination series. It's a series of 3 doses given over 6 to 9 months, usually as a child. If needed, you can have a booster later on in life. So as a healthcare worker, just about every healthcare worker has had the hepatitis B vaccination and are at very low risk of acquiring hepatitis B. Then finally, we'll talk about hepatitis C, and similar to hepatitis B in presentations, but hepatitis C most commonly, most often through shared needles, infected needles and injection drug use. Also STI transmission, sexual transmissions. There is antiviral treatments for hepatitis C, which are very effective, but there is no vaccine for hepatitis C. So to sum them all up, we've got our 3 hepatitis A, B, and C. There are more types of hepatitis than these, but these are the 3 we are going to focus on. Different routes of transmission, whether or not they're acute or chronic. Vaccines are available for A and B, but not for C, although antiretroviral therapies for hepatitis C are very effective. And then what's your risk as a healthcare worker? What do we need to be aware of? Risk levels. So any major complications therein, but all these are hepatitis, diseases of the liver, infections of the liver, but they all present a little bit differently, and their routes of transmission are all different. Next up, let's talk about tuberculosis. And tuberculosis is pulmonary disease wherein you have inhaled this bacterium, and we categorize tuberculosis as latent or active. In latent TB, you've got the bacteria in your body, but they aren't multiplying in the body, they aren't growing, doesn't make you feel sick, you don't have any symptoms, and importantly, in the latent stage, you cannot spread it to another person. It can advance, but in the latent stage, you cannot spread it. In active TB, this active disease, they are actively growing inside your body. They do produce symptoms, and you can spread it from person to person. And if not treated, and treated somewhat aggressively, tuberculosis can be fatal. If you are suspecting tuberculosis, some symptoms to look for. The big one's fever. Maybe it's a little bit of blood-tinged sputum, a little blood in their cough with that persistent cough. Big ones that kind of set tuberculosis apart from other disease processes. Frequency of night sweats. Patient will be reporting night sweats and unexplained weight loss. We're not just talking a couple pounds. Significant and unexplained weight loss. Next up is meningitis. So meningitis, classic symptoms, that neck pain, that neck rigidity, may go down into joint pain as well. Look for headaches, light sensitivity, any neuro effects, but that neck stiffness, that neck pain, and headache, along with fever, classic signs of meningitis. So why the headache? Why the neck stiffness? What is meningitis? It is an inflammation of your meninges, your meningeal layers, and an infection within those meninges. So you've got swelling of the layers around your brain, and including those layers around your spinal cord. And with meningitis, is it bacterial? Is it viral? The answer is yes. We can have bacterial meningitis. There's a certain bacterium that'll cause bacterial meningitis. Most common in younger adults, in teens. That meningococcal vaccine is important for them, especially living in kind of close quarters when you send them off to college. For example, they're living in dorms. In those close quarters, it's easy to spread bacterial meningitis. There's also viral meningitis. So you've got a viral disease, and symptoms are going to be similar to bacterial meningitis, but bacterial meningitis usually carries the more severe symptoms. Viral meningitis can be a little less severe, but nonetheless meningitis or a meningitis infection. There is also fungal meningitis. We won't highlight that one. We'll just worry about bacterial and viral, but just know that there's also fungal meningitis out there. Some characteristics of meningitis. The hallmark is that nuchal rigidity, fancy way of saying neck stiffness. So a patient's going to report neck stiffness. If you manipulate the neck at all, they're going to have some rigidity there. There are also a couple signs, like Koenig sign, Brudinsky sign, that help aid in our diagnosis of meningitis. First, Brudinsky sign is easily done. You have your patient just laying on their back. If you flex their neck upwards, bring the chin towards their chest, this is going to cause a reflex of the knees the knees and hips flexing upward. So they'll have flat legs, and then as you raise their neck, their knees and their hips will flex at the same time. Kerning sign is similar, but just a little bit different. You've got the patient lying on their back again, and then you take one leg at a time and bring it up. The knee is bent at a 90-degree angle, and as you go to straighten that knee, the patient's going to complain of some severe lower back pain and have an inability to extend that knee. They'll actually fight you on it. So if they're fighting you on it, they've got lower back pain. With that, that's a positive kerning sign. Now let's talk about some other infections, including tetanus, which is an infection of a wound, some open wound with this tetanus bacterium. We do have a immunization for that. Starts with a DTaP, so diphtheria, tetanus, and pertussis is given as a child. And then after that, we get Tdap boosters that are recommended every 10 years or after each pregnancy. So we do have immunizations for it. If you contract tetanus, think tetany, so we might have the jaw muscles tightening, difficulty breathing, difficulty swallowing, just rigid muscles, especially in the face. Then rabies. Rabies is viral infection of your central nervous system and transmitted from infectious animal to human, usually through bites, through scratches. Rabies is scary if you suspect that your patient has had contact with a rabid animal. If we can begin what's called PEP, post-exposure prophylaxis, as soon as possible, within, at the very latest, within 2 days of that exposure, of that bite, we can avoid the rabies infection growing and manifesting within the patient, because once symptoms develop, there's no approved treatment for rabies. So the virus will take its course, and from that point, it's just symptom management. So we need to identify it early and begin that prophylactic treatment, post-exposure treatment, as soon as possible. There are a number of mosquito-borne illnesses, mosquitoes as the vector, and big four to mention: dengue fever, West Nile, and Zika. These are all viral infections spread by mosquitoes. And then there's also malaria. So malaria spread by mosquitoes through mosquito bite. Malaria is not a virus. Malaria is actually a parasite that causes this infection. And lastly, let's mention Giardia. Giardia is not a virus, not a bacterium. It is a parasite found in contaminated food, contaminated water. It causes dysentery. Heavy diarrhea, loss of electrolytes, heavy loss of electrolytes, and dehydration, if not treated fairly aggressively with rehydration and replacement of those lost electrolytes. It can lead to hypovolemic shock, can lead to death. So Giardia is pretty important, pretty significant. So if you suspect your patient of dysentery, we need aggressive rehydration. Now let's run your calendar back a little bit and talk about infectious diseases that are more prevalent with children. First up is measles, a highly contagious virus causing a telltale blotchy red rash, and primarily transmitted through respiratory secretions. Then we've got mumps, so another very contagious viral disease. And you'll see swelling of the salivary glands, maybe seen on one side of the neck or both sides. So this is again through transmitted through saliva, through through droplets, so we're taking droplet precautions here. If you've got a mumps patient, we see this one-sided swelling here. So if you see swelling there, it's, swelling of the salivary glands, we can be thinking mumps. And then we've got rubella, so another very contagious virus, and transmitted through secretions, droplet sprays. And telltale sign here, there's this diffuse, very pinpoint rash that spreads, that extends, starts usually on the forehead, on the face, and then extends down to the torso and finally to the extremities. And again, good news. These three things, measles, mumps, and rubella, there is a vaccine for it. So make sure to get vaccinated. This is MMR is usually given during childhood, but you can always get a booster. Or if you haven't had an MMR, please go out and schedule an appointment to get poked for your MMR. Next up is chickenpox. So chickenpox, we've got these itchy, irritating skin eruptions. Child will have low-grade fever. It is becoming less and less common to be seen because, again, good news, there is a vaccine for it. There's a varicella vaccine to help prevent infection from that varicella zoster virus, which is part of the herpes virus family. So chickenpox is passed directly through contact and airborne droplets, so it's very contagious. And as you age, symptoms become worse if you contract chickenpox as an adult. So if you haven't had a varicella virus and you haven't had chickenpox, please think about receiving that varicella vaccine. Chickenpox is kind of a one-and-done disease, one-and-done infection. You get chickenpox, that virus stays in your body for your lifetime. So you're not going to get chickenpox again. It may pop back up, and it'll pop back up later in life as shingles. So if you have had chickenpox, be aware that you may develop shingles later in life. There is a vaccine for shingles to try to prevent shingles, but you are at risk for developing it. Then we've got pertussis, or whooping cough, bacterial infection causing inflammation of your entire respiratory tract, causing violent coughing episodes and causing that telltale whooping sound from the cough. Very contagious, easily spread through droplets. When you've got 18 coughing kids in a classroom, someone's going to get it. There are vaccines for pertussis. Again, good news. There are preventatives for it, but you will see outbreaks of whooping cough from time to time. So, your main childhood illnesses, infectious diseases. We've got measles, mumps, rubella, chickenpox, and pertussis. We now have vaccines for all of these, so very important to vaccinate and help control the spread and the outbreaks of these diseases. Next up for our infectious diseases, let's talk sexually transmitted infections. And we'll start here with syphilis, a bacterial infection. It comes in different stages: primary stage, secondary stage, and then latent stage. That primary stage of syphilis is within first few days, weeks, wherein symptoms manifest themselves. You'll have sores and cankers on the genitalia. Those, even untreated, will go away and go into the secondary stage, in which the patient is largely asymptomatic. But in that secondary stage, you are still highly contagious. So primary stage, contagious and symptomatic. Secondary stage, asymptomatic, but still highly contagious. Following that is the latent stage. And that latent stage, you'll have recurrent episodes of those secondary stage symptoms, those kind of like very minor symptoms. So you've got recurrent episodes here or there. That latent stage maybe lasts from a year, several decades. This is long-term syphilis. It can go into tertiary syphilis or neurosyphilis. And neurosyphilis can occur at any point of the infection, any time of infection. It affects your central nervous system, your sensory organs, and kind of hear stories of figures who this long-term syphilis, behavioral changes happen, and neurologic changes happen. Herpes virus infections are quite common in the U.S., and the herpes simplex virus comes in a couple forms, HSV1 and HSV2. That's oral herpes and genital herpes. So cold sores, HSV1. Genital sores are going to be your HSV2. Other STIs to note, bacterial infections for gonorrhea and chlamydia. We'll talk about gonorrhea here in just a few minutes, a little bit more. And then HPV, which has become the most common STI in the US. And HPV usually goes away on its own, but if it doesn't, there are high-risk forms that can then progress to varying types of cancer. Now, we can't talk infectious diseases without talking about antibiotic-resistant infections. So how does this happen? How does this work? How are bacteria resistant to our antibiotics? Well, let's start simply. There are a bunch of germs in your body. You've got an infection, and maybe some are drug-resistant, right? We've got antibiotics, and they kill all the bacteria that are susceptible to the antibiotics. They leave behind the ones that are resistant to the antibiotics. Those resistant bacteria are the ones that now grow and take over and replicate, and they can even give their resistance to other bacteria, not through replication, but just through like a little cloud share, right? So they can give their resistance over, and through spreading, we get antibiotic resistance. Digging a little bit deeper, there are a few ways that bacteria can fend off and defend against the antibiotic. They can modify their cell walls and just become impermeable to antibiotics. They go after bacterial cell walls. They can inactivate the antibiotic. They can produce substances that just inactivate, let's say penicillin. There's penicillinase, there's beta-lactamase that these bacteria produce that will inactivate the antibiotic, or they can just pump out the antibiotic. And I laugh because it's just like a little bacterium taking in an antibiotic and then just spitting it right back out without any effect at all. It kind of makes me laugh. So there are a number of different defense mechanisms that these bacteria have that create these drug resistance. When it comes to antibiotic-resistant infections, the CDC does categorize them into urgent, serious, and concerning. Your concerning infections are kind of your up-and-comers, and they're watching them. Under urgency, right now, we've got things like C. diff, and drug-resistant gonorrhea is in there. We'll talk about a few of these. Under serious threats, we've got, you've probably heard of VRE, vancomycin-resistant bacteria, and then your methicillin-resistant Staph aureus. Your MRSA has been out there for quite a while, but there are a number of urgent threats and serious threats under the CDC categorization. And under these categories, the CDC estimates that of the 18 resistant threats that they have on these categories, 6 out of those 18 cost us more than $4.5 billion annually in healthcare costs. So the MRSA is up there, VRE. We'll talk about CRE here in a moment, but just these 6 cost the healthcare system quite a bit and are just highly urgent threats. Some resistant infections to highlight. One is C. diff, which causes just life-threatening diarrhea. We've got this bacterium, and these toxins invade our patient's intestinal wall, causing ulcerations, runaway diarrhea. Needs to be treated pretty aggressively. Then we've got CRE, which is carbapenem resistant, and carbapenems are a very large categorization of antibiotics that we have. So this bacterium is resistant to nearly all of our typical antibiotics that we typically prescribe. And then we talked about drug-resistant gonorrhea. There's a drug-resistant gonorrhea out there, and currently about half of all gonorrheal infections are drug-resistant. So it's a very concerning up-and-comer on that CDC list. As always, if you have any questions, please let us know.